right, thank you very much. My name is Wellington Oyibo, a professor and consultant medical pathologist. I am the lead of this project, the RDT QAQC project on the job supervision, training, and mentorship of this program. And we're also doing stability monitoring of the rapid diagnostic tests and also still assessing healthcare providers' capacity to perform RDTs and to see overall how the healthcare providers is implementing the malaria diagnosis and treatment guidelines of the country that requires prior mandatory parasitological confirmation of malaria before treatment, and then how the records are properly kept, was testing done properly, documented, and we want to see how this is affecting the overall data in the facility health management information system, the monthly HMIS reporting, and of course how overall it will affect the DHIS reporting in the states. And one of the reasons why we have carved over all of this program together in this global fund support is to bring value for money by introducing, of course, infusing a holistic intervention, not just building capacity for healthcare providers to perform RDTs, but to bring the stakeholders back who are likely going to take very significant and critical decisions for the states on the positive aspects and how the statewide implementation can be accelerated. So we have in this program, in this current form, one-day orientation and planning for the medical lab scientists that will be visiting the healthcare facilities. And when they visit, they need to understand the current trends, understand the purpose, understand the tools that will be used in collecting information from the health facilities and how they will interface with the healthcare providers in implementing this intervention. And this is unique because they will bring in their leadership, they will bring their understanding and take it to that level of care at the primary healthcare setting. And when that is done, carefully the healthcare facility raising non-conformities from what they see, then they can institute corrective actions. These actions will have to be documented so that in subsequent visits, they want to see how the non-conformities have been cleared. And in this project, like I said, we'll come back to the stakeholders. We just had this meeting with the stakeholders, telling them why we want to do what we're doing. And chief of all, we're even doing what has been initiated here, which is the RDT archival, which will be monitoring and to see how the test tallies with the healthcare facility reports. So, and they are welcoming this. And rather than writing reports which nobody will read, say, no, just bring it here and fund it. And you can see the argument, the discussions around the stakeholders and how they're going to support this project, how they're going to receive the results. So one important outcome we're looking at is that because we have seen now reported very high test positivity rates, TPRs, from the DHIS data, we will ensure that from our work, we will be having a better, HMIS reporting, and therefore more accurate test positivity rate reporting, and of course seeing how the test is catching up with the use of ACTs, and then that forms the success that we were looking at, and therefore the states can contribute meaningfully in meeting the malaria case management targets objectives. which are very clear that patients presenting with the symptom of malaria are tested and then they're treated appropriately. And if it's not positive, then they are managed them accordingly. And that becomes a very important target for us. And with that, the healthcare providers are happy, the health facilities are happy, the state government is happy. And then apparently we'll be able to see more refined data. And they can query what is in the national DHIS data if it's not having any correlation. So that's what we're doing. The advantage of all of this is that we work for the common good of the people. We stand with the people, we stand with the government, we stand with the objectives of the Global Fund principles, why they are funded. The funding is to create value and create impact, so we'll be able to have the achievements. And we'll see that the data is changing, and overall we'll see again that the entire contribution from Ogun State is reflecting in their clinical cases that are reported, and therefore on the burden of malaria description in Ogun State. So that is the bottom line, and we are excited about this. We are excited about the opportunity of the Andy Center of Excellence for Malaria Diagnosis at the College of Medicine being able to provide this leadership in the interventions in the 13 Global Fund states. So we look forward to all the results. We look forward to all the series of interventions we'll be bringing on board every 6 months. Thank you very much. Wellington Oyibo, Professor and Consultant Medical Parasitologist from the Andy Center of Excellence for Malaria Diagnosis that is embedded in the Center for Transdisciplinary Research in Malaria and Neglected Tropical Diseases in the University of Lagos. Thank you. that and then speak to it. They show evidence that they're using it in their state, in their facility. So how do we see that valid point from the DPH? So, Malaria Program Manager, GM and no GM, so you attend all the program reviews. Okay.
We leave the issue. Good afternoon. Good afternoon. And we want to appreciate you, sir, for your deliveries. Well, on the issue of primary health facilities, before we leave that to the issue of global fund, the practice in our facilities when it comes to RDT and treatment of malaria, it was in the past that we have issues with treatment of malaria without positive result for RDTs. That was in the past. But in the past few years, there is no treatment of malaria without getting results.
So you saw the data?
Well, I don't know where you get the data.
He's from Abeokuta South.
I'm from Abeokuta South. I'm from Abeokuta South. So this is one thing we are sure of, or I'm personally sure of, that none of our facility will take care of malaria without result from the RDTs in all the facilities in Abeokuta South. Even when they have issues with supply of this RDT, I'm the logistic officer for that local government as a pharmacist. We try as much as we could to provide this for them, the RDT, because they know they will never treat malaria without RDT, without the positive result from RDT. On the issue of maybe clinical basis when the test is negative, it's a different topic on its own.
No, it's not a different topic. It's not the same.
Yeah, it's not topic. I mean, it will come under a different discussion.
Yeah.
But for what is the standardized practice there is what I've just mentioned. And when it comes to about reporting too, we have our malaria forecast here. Yes, truthfully, there are some facilities that are global fund supported. In the past, what I know is because of the report from some of these facilities, the global fund or the partners are not getting. So they are extracted, they are removed from those that they are supporting. But now, reporting are coming from all the facilities. Of course, those facilities that were not supported are still there, but reports are coming from all the facilities. So for whatever reason,
that's what we are querying now.
we are talking about those who are tested positive, those who are treated, because the report must come from every item, every drug used for all the patients. Either it is ACTA that we call AL4, AL3, AL2, it must be reported. And as I said, I'm the logistic officer for that local government. We have a unit, the logistic management coordinating unit. And on bi-monthly basis or monthly basis, we ensure that all these reports are entered into the dashboard of the NHMIS and all the rest. So I don't think it's an issue of reporting that we have some facilities that are not supported. I think it should be found.
So, number two, I'll ask you a question now. You see, we are in the DHIS2 data. That's a report. And what the report is saying is that some things are not properly done. Now, let me tell you something. Healthcare providers believe it. They are likely going to report a negative RDT as positive so they can treat. Okay? And that's an issue. And as long as that issue persists, it's not only in Ogun State. As far as it persists, you continue to get this data. That you now have 130% of people treated with ACT. And test positivity rate is 25%. And it's because everybody said they want to report. They say, share report. Okay, we'll give you reports. The report now is not useful. So one of the things we want to do, we'll go to the health facilities and have interface with them. And whatever we see there, we are recording. And then we're telling them this and that. And now we're archiving our meetings, right? So in the next 6 months, we want to see a change.
You cannot remove these facts. You know, either because it is obvious that you are seeing this patient with febrile, all these symptoms that have to do with malaria. It's not by the health workers. Even the doctors will also do the same. And you are very sure that this patient will do well if from all the symptoms on anti-malaria. That is one side. The second side is The report must indicate that test was carried out, that this patient is positive. That is where you get what you are saying. They have to do that because that is what the government is a policy, and that is what the government is expecting. So they have to write maybe yes, the audit is positive because he has to carry out. I'm not saying a physician will do that, but all health workers, because we are the one that we supervise them.
Everybody does that. Right?
Okay, so we are the one that we supervise them, and we will not tolerate or will not want to look on any treatment card with a patient treated with ACT without seeing the positive result from the lab. So the problem will persist if we do not balance this situation of symptoms of malaria, and you should look into somewhere else without no, it cannot work. Thank you.
It's a major issue. Thank you very much. And the health attitude, behavior is very important. And then and that's the reason why the PhD board started supervisory integrated. So
good afternoon, everyone. Thank you for your presentation. The area I want to speak about is the area of the effectiveness, sensitivity, and specificity of the RDT. I'm aware that the best RDT will not detect parasitemia that is less than 100 parasites per microliter of blood. And that is where microscopy comes in to bridge that gap, so that the clinician can do the needful, and those who are having malaria will not go without being detected in the laboratory. So in this program, how do you plan to reconcile that data? I don't know whether you get me right, because I know there's another program which is microscopy as gold standard. So how we bridging the gap of this limitation of RDT and the use of the microscopy? Thank you. Then facility usually gets RDT, free RDT, and they are carrying out the RDT malaria test free for the patient. And patients already know that when they get to the hospital, they are going to get malaria investigation done free. They have free kits. Now, in the case of the microscopy, it's not free. In fact, some facility who doesn't even have free RDT, they will charge for it. So this is a type of confusion for patients in some of the facilities. When they charge for money because they want to carry out microscopy according to what other program has called, and they are requesting for RDT that also has some level of limitation. Thank you.
Good afternoon, everyone. Once again, I want to appreciate Prof for the lectures, and I want to request that I think it would be better if some of us can, if we can get the soft copies of those lectures, so that it will be useful for our people. Although I'm worried about some things before, but I got clarification from my colleagues here, especially when I had a global fund supporting some facilities, that is secondary facilities. I'm not concerned about secondary facilities, but that is my area. Then I now ask the question, which facilities are being supported and which one are not being supported? And what are the criteria for choosing those facilities that are being supported? And when we want to get a reliable data for the state now, we are not talking about data alone, but the welfare of our people. So when some facilities are being supported, at least they are gaining more grant than the other facilities. And then we still expect data from those other facilities. Then how are we going to get the reliable data from them? Because our people, when they go to these facilities, what they know is that they expect either free tests and free treatment. But when they get to some facilities, they pay. So it is now become a problem. That I mean, they said that we are not, that I'm expecting free drugs, and now I'm paying for the test, I'm paying for the drugs. So that has been my worry. That okay, but then my colleagues then at least are giving me some highlights on what is really happening in the field. But I will, just as the director of public health has said, I think it would be better if everything had been the same for all the facilities. I don't know the criteria that been used, because when they are talking about the program, so we are talking about the states, we are not talking about part of the states. So I will like that if it can be extended to all the facilities, so that at least we will now be talking in the same tone. Not that one facility is supported and the other not supported. Then I think in training like this, I know that is few of my people from my facilities are here. Very, very few. I think about 3 or 4 from secondary facilities. But this
they are all.
Yeah, okay. It's only from supported facilities.
No.
There are some selected facilities.
They are quality assurance officers for the state.
And they can walk.
They can walk around the state.
Because my request is that they have to walk around the state and go to the other facilities.
Yes.
So that
Yes.
like instead that training and then they maintain all those facilities. All the facilities. Once again, thank you for the lecture. So and we pray that God will continue to strengthen you. Amen.
Thank you very much. Okay, thank you, Prof. I also want to appreciate the impact of your lectures, and because so much have been learned again this morning, especially concerning the issue of tests in malaria. I want to zero down to the issue of commodities, which is the drugs and the test kits for malaria. I happen to overheard you when you were saying that you deliberately asked the Director of Pharmaceutical Services to come to this program. And I quite appreciate that. Because the issue of supply or distribution of these commodities actually lies with the unit we call LMCU, which is Logistic Management Coordinating Unit for the states. And this one domiciled the Department of Pharmaceutical Services, Ministry of Health. The basis is such that it is the quantity and quality of reports that comes back that inform resupply to all these facilities. But how it started with the Global Fund, because Global Fund came through the National Product Supply Chain Management Program in Abuja, that is charged with the responsibility of this distribution, procurement and distribution of these anti-malaria drugs and test kits. They now come in and choose certain number of facilities that they are going to supply, that are going to be supplying on a basis, on we call it reporting cycles. And it is these reporting cycles that they have been following. When they chose the initial number, I think the malaria manager should be aware of that. When they choose the number of facilities to be supported, she should have reason why, in the first instance, why they chose that number out of the number of facilities that we have in the state. But along the line, the instruments being used in the state, which is the LMCU, were made to understand that all these facilities still has they still has opportunity. If the reports whatsoever they have been given, if the report comes back adequately, they still have the opportunity to even scale up the number of facilities that we supply. But for some time, you know, when the program started, we have issues of some of these facilities giving adequate and proper reports. Some will not give reports at all. Some will not give it adequately. Some will give reports, but those reports are not of quality that can actually speak to what they are using. So with all these challenges, and what they said was that once that is happening, any facility that is giving them such challenges will be dropped. And before we know it, some of those facilities were dropped later. And that is why we asked them reducing. But at a point, we went round, especially concerning these test kits. We discovered that is actually not that they are not reporting, but there is a column in their reporting format that says that it's not only the one procured by the global fund or given by the global fund that should be reported. The ones that they are also using, buying, should also be brought in, so that the next supply will actually speak of what the state is using or consuming. But we don't see this happening. We sampled some facilities. We went there when we go for MSc, trying to see what is happening. Some of them will say, how can I be reporting what you did not give us? I don't want you to go and report me that we are buying test kits in our facility. So that's why we just said no. Nobody is after reporting you for anybody. What we are saying is we want to know what you are actually using in this place. And the reason is this. Not only that they are going to scale up the number of facilities that we supply, they can also increase the number, the quantity that is coming to that facility by simply reporting every other one that is coming from another side into your report. And all what we need is figure. Just give us that. You gave us 20. We use 20 from your side, but we have additional 15 that come from other. That means 35. Because it is this total that will inform what they are going to now resupply the next phase. But if you don't do that, they will keep giving you the 20. But that became a serious challenge when an issue, when the triangulation process started. Because triangulation will now say, on the service data, we discovered that so many people were treated with ACT, but when you are reporting the test, you just say 20, but we have 35 on the service data. What is happening? That means you people are giving us wrong, and that is where the issue becomes escalated. And that was how we have been having the challenge. But we went around to educate them. We went around to tell them, and they are now coming up to report those ones. When you are analyzing that of the Abeokuta South, I can see it there. Because you see that the test rates now begin to increase later. It is because they are reporting the actual consumption. And because of that, they are giving them more of those test kits And that is what is making them to meet up, and now you have a better reporting rate for the Abeokuta South. So these are the things that has been happening. So it's the unit is living up to expectation to make sure that what is reporting is adequate for them to supply back to the state. But as for the issue of increasing number of facilities, I think it's a program, it's a public health issue, and I know it's the city. They can take it up with the Global Fund or whoever is relevant to that, to make sure that every facility in the state is covered concerning this. So, but in terms of ensuring that what is coming from Global Fund is getting to the facilities, we are doing all what we could in the state to make sure that everybody gets what they're supposed to get. Let me stop here.
Thank you.
Thank you.
So, how did the segregation start? Because I remember that it's about reporting. And you know, Global Fund, they put value to money. One person which primary healthcare board and malaria program should not joke with this. He's the one that spoke now. He's the one that has the answer. He has the key for product supply. And whether a far more active, now integrated permission is going on. So while that one is going on, it will be good to incorporate him into the high-level discussion process so that facilities can benefit. This is what is happening. The state budget is tied on so many things. There's no free money for many things to happen the way you want them to happen. Therefore, opportunity for support like this, for my own consideration, must be used optimally. So the more facilities report, I know it's reporting. In fact, that's the reason why private sectors will not benefit much, because they'll be a down on reporting. They'll be a low and poor on reporting. And Global Fund says, well, if you do this, we can give you a commodity, we want to know. And the point of advantage and benefit is what he just explained. However, we are stakeholders now, and we have one state. You know, one of the things we say we'll do is that we have an exam to do, right? And we know the questions that will give us the solutions. Let's answer those questions from the insight we've got as a state. Stakeholders are very important. In fact, critically, stakeholder engagement is one positive way of us resolving challenges. The mystery man has appeared now. He's the man that has the cash in his pocket, but the cash is not in his pocket. But when they are satisfied, the commodities come. And then we now talk about judicial use of commodities, accountability, and how that can happen. Ogun State must benefit, both for the RDTs, for the commodities, for the next, they must benefit. We will deal with the healthcare behaviors attitude, but we'll hear from you how that will work. And if you permit me, maybe I should just answer that question before you go. Or you want to answer the answer of? Okay, you have a side. Okay, go ahead.
Just to concentrate on what you have said on the high positive rate. As malaria focal person, like in the IG, like for the past 3-4 months now, for the facility we are employing them that to keep their cases, their RT cases, so as to monitor their positive rates. For all the facilities now, we used to do facility monitoring as every month. Each malaria focal person will visit all the facilities every month, just to check their data, check their register, how many positive patients they had in their register. They will count the RT cases, just to ensure that the number of RT cases positive, I didn't tell you the number of total RT positive in the register, to be on the same page. Therefore, the money on the use of drugs too. At every 2 months, we need to visit the facility too, just to cross-check their source documents. We check their inventory control cards, the OPD registers, daily consumption registers too, We count how many audits have they used from the registers. From the stock levels, we need to do to compare that. Are they all the same? So that we don't have the disparity between the positive and drug use. In order to reduce the positive rate, then I can confirm that from the last 5 months now, the positive rate has been reduced. Since the facility people, they knew that every month the malaria person will come to our facility and check our cases. At that time, the number of positive. So we are trying to reduce the positive rate to confirm, to check the confirmed cases and the cases used. Sir, we are promising you that as malaria focal person, we keep up the health workers to tell them that the audit is the most gold standard of diagnosis of malaria, so as to reduce the clinical diagnosis or not positive and they are giving safety. So we need to improve on the health education to health workers too. We do all the job training for the health workers to tell them that not all fever cases are malaria. They need to probe further to go for other tests just to confirm before they can treat malaria.
Thank you. So, you have already initiated, and you already do it.
Yes.
I tell you, how is it going to work? Because the facilities where they will be going now, they will tell them to keep the cassettes.
Yes.
And they are providing nylon bags and labels where they will put those.
Yes.
How will it work with what you are doing?
So this is what they, for the whole month now, we told them we should keep it monthly. The added use added cases, they should keep it monthly. At the end of the month.
Do you give them a bag?
No. Just find a nylon.
No, it's the same as we have a nylon bag.
Okay.
And then we have a label.
No problem.
Where they will be putting it.
Yes.
After you do your work, they will still remain there anyway.
Yes.
Okay, they will remain there, they won't take them out.
Yes.
Because from next week, when they will be going to the work, they will be doing that. They will give them nylon bag where they can sleep. We collect both negative and positive. Is that what they do for you?
Yes, sir.
Good, so we are doing the same thing.
Yes.
What happened to the ones you checked before?
So you tell them that after 2 months, and you've checked it already, since it's confirmed, they can discard it.
So this one now, they cannot discard it.
Okay.
Because the exercise is still ongoing.
Okay.
It's still ongoing.
And our own is coming in addition to that.
We will tell them, like it is now, the exercise is talking about, this bi-monthly monitoring is ongoing presently.
Yes.
So this week we will be occupied with that exercise. So we will tell them that a similar operation will be coming up next week, so they will not discard it.
So they will keep it.
They will keep it for this
We
purpose.
will go there every 6 months. And 6 months we want to see all the things together. And after a while, because there's no point celebrating the week.
It's the negative positive.
No, the negative positive will keep them. And then we have a form where we are going to give to them when they start. So that we don't say there's additional form, but if you did audit, please just put the results. They will fill it every month. As the patient is being tested, in that facility, those are positive, negative. At the end of the month, that form, they will put it inside the nylon. We will come and cross-check that form and then cross-check your records as well. Now, I'm very happy with what you're talking about. So by the time we move forward, we'll consolidate this. The state says this is what we are doing. Like I said, those who are being washed, the moment you are being washed, you stop stealing. Everybody is likely going to steal. But the moment you know that they will cross-check that money, your stealing stops that day. There's a potential for everybody. You do not supervise work, likely the work will be dirty. The moment you bring supervision, they start. That's human being for you. That's human being. And what the state wants is just, let's do value for money. If we keep on with this process, it's not going to help us at all. Now, we have something we did not do. Please. We will take that as a form of exercise. I'll come and answer these questions. So we'll work with the focal persons, and you have them one focal person per state, per local government.
For one local government.
For one LGA. So please, we'll work with all of you in this RDT archival. We have some ideas. Osun State have shared quite a lot. One of the things we're going to do is how we work with you to say the ones we have checked, we'll destroy them. They won't go back to the system again. Because sometimes you see that they recirculate them. So we all will agree and say, Ogun State, this is what we'll do. Once you bag, we bag and bag and bag somewhere with the state agency, they either incinerate them or destroy, or they will not go back to circulation. So we'll work with you. We'll do a small exercise now. I want to take a group photo and we'll come back here. Hey Joe. It's just some walking downstairs to help our respiratory, our circulation, our everything, our physique, our everything, and then we'll come back again. Let's take photos downstairs, please. And I'm liking it because something is being done. We have a responsive state. We have a responsible state, and we're happy. And every other thing that is coming, I'm sure it will still work as well. So please come.
It's always first.
Are you talking to the Goshan like me? Are you talking to the Goshan like me? I will let us now. Come first. State of excellence. Let's just go downstairs, please. Take a photo. Show you that comes from root cause exploration. The state is doing something. And I know that we all here will be able to walk in that light. So, I then put that out. You know, when I was presenting, I said something must be going. We should learn something from there because it's been like a little consistent, even though we have some over-treatment there. But it's good that we'll learn. So we'll come back. There are a series of questions, and we're happy about archival and how we can work together with the focal persons visiting regularly. We would like you to have data, share, and to see how it's being done. And then it's the kind of data we're going to bring here. And Ogun State being the map with slides. When the state look at how much can donor do for your states, then you say, you give us one, we support ourselves. And when the gap analysis is done, it helps. Now let me just respond to some issues here, which we are going to look at. Now, coming from what we planned, our eyes are open, kind of. And I'll say this as a response to some of the questions. Whether they get free tests, government will say malaria test is free, and they won't charges. Some states will recommend how much NP. Some states recommended is 1,500 for NP, or some 2,000 in public health facilities, some 1,000. And that's what the charge me from me. And below health facilities, you do use their DROF to get commodities. Those ones are all helpful ways in making sure that the facility is not dry and responded. So, I'm happy that the PhD is having coming in and all the in-house supervisory disease and training to help the process. They recognize issues with the data and they're trying to sort that out. Stockouts is good at their result. We look at the big range by doing that. So I'll start from here. Quality supply, we need to work with the seekers. What's available? Then how is that treatment of malaria? Okay, that's been talked about by the results. We look at the root causes. I will talk about RODTs will not detect parasitemia of less than 100 parasites per milliliter of blood. I made it actually very good. WHO put a benchmark of 200 parasites per milliliter of blood. But you know how it is. do not detect parasites. They detect antigens. And this is how this is the rich protein too. All the antigens, which is most abundant. HRP2 is one of the most abundant antigen, far more abundant than the Plasmodium lactate dehydrogenase. Plasmodium lactate dehydrogenase is an enzyme that is always produced by viable parasites when they are alive through the glycolytic pathway. The moment they're dead, the enzyme begins to reduce, so they don't have antigenemia in the peripheral circulation. And because an enzyme too, they are fragile enzyme. But HRP2 is a solid protein and it's rugged. So what you see is abundance in the vacuole of the parasite, infected parasite, and then in the erythrocytes. When the parasite is killed by medicines, the HRP2 remains and it stays there long. Just to let you know, it stays there long. And until they're taken out from the spleen, they may stay in the body for up to like 6 weeks. Now, as a protein, they are very rugged. You can even boil them. What we see now is that the HRP2 based kits even overdiagnose. Another infection, or maybe no infection, you still have HRP2 in the patient. So you need to be oversensitive. Now, for most people who have febrile illness, they are not those. Only few people have submicroscopic parasitemia. Quite a number of few people, and very few, and insignificant few. We have parasites having clinical malaria at 100 or at 200. The data we see, most of them like 2,000. Of course, we see at 500 parasites in few will be having. But majority of the patients we see that they used to have parasites 1,000, 2,000 parasites per million of blood in our current control setting. So, how you see this in our database, how it is detect even as low as 32 parasites per million of blood. But we say if you put all this together, you will not even use microscope. Because PCR limits of detection is found up to that 1 copy. And we know that when we use the best microscopists, they give you 78%. I'm talking about level 1s. You compare with PCR, you see PCR detecting more. So, and how it is, here as it is, they will give you 95%. And you cannot put microscopes. Even if you put microscope here, you now talk about capacity that we're talking about. How many level 1s or high level microscopists do you have in these states that can help you do it? But microscopy is valuable because when you look at things, go forward and back, when you look at another test, you can use microscopy as that for that test. But it's not the final. When you have microscopy, you have sub-microscopics in many areas. If Abeokuta South does well moving forward, parasite density will begin to reduce, transmission is reducing, then you might need another new test, not microscopy, in another new test. With lower limits of detection. Limits of detection is an important criteria how you qualify tests. But on the general note, all tests have their limitations. All tests have their limitations. There's no perfect test. PCR is good, but it's not accessible. The important thing you see here is that parasites, the microscopies that I give you, 100 parasites in the bit of blood are very few. I want to talk about microscopy. It's not a microscopy, yes. When you are fully and properly on top of that level, they will do well with lower levels of detection, with lower detection. But you must produce that capacity. Produce the Ireti Primary Health Care Center. Produce that one in the Promotion Primary Health Center. Produce that one in every health center. It's not possible. Even the ones who are very good now, they don't have the right equipment to work. The ones who are very good now, they don't have right microscope, some they don't have lights. There's no solar in that one, so they can't even do it. All around time is high. People walk, either walk or look at step or look. You know the issues. So where does it happen? So if you want to make progress quickly, use RDTs. And one thing about the argument around the argument or discussion around gold standard. What is a gold standard? Gold standard does not mean it's the best. Of course, as you know, it's not the best. RDT we do more regularly and consistently. Morning, night, afternoon, anytime, the RDTs are there. You are on call, you are there. And you look at workload, it's an advantage. It will help you do many things. But the microscopes are not consistent because they're human beings. Subjective, as we know, theoretically. Now, what is a gold standard? Why did they call microscopy a gold standard? It's not because it's the best. It's a gold standard because you can see the parasites.
And the species.
You can see it. In fact, sometimes species is even different because it's tricky now. You cannot differentiate Plasmodium noelsi from Plasmodium malaria with your naked eyes. You cannot differentiate it. So when it comes to species, let's leave that one because part of the qualification for ECAM, even though you can do detection, species can bring you down. So it's ordinarily the big nucleic acid, I would say. Then you are fine. So, and let that one, all those things not be a roadblock to our implementation. I want to tell you the truth. We are doing 2 clinical trials now. If you come to my rooms, you will see I'm talking about multiple thousands of slides. This year alone, I can tell you I've seen 100,000 slides. They are all kept in one place of different qualities. And then those using RDTs on or didn't use on, you see them there. But even now, there's some innovation coming because in our own platform, we have AI-enabled system. I have 2 of those machines. One of them is auto and AI embedded. We just did a clinical trial. It will put the blood, 5 microliter of blood, it will dry it. It will take the pictures.
How about affordability?
I'm coming, man. It will read RDTs and innovation. It's we work on it in our community organizations to see consistent policy. Then the other one is whatever slide you give, just put it there in the scanner. When you scan, then the points already are not set. Machine learning, it will give you the result immediately. But the microscopies are important. They are of brand and will be with us. That they want to be directly, whether it's AI, they will direct the process. Whether it is anything, they will direct the process. And they will be available to state and they are useful. And that's why in this particular work now, they are the most easiest people to go and talk to this thing. So they are very useful. At different times, the utility, in fact, they are going to be expanded more. To be on brand. We spoke about so many things yesterday. Talk about diagnostic technology, how many people how it is. They are better, they are very good there because they check the detailed information and they can help explain more, do many things, and they will take their role. But if we say this is gold standard, I've just told you that's the end. If you do those diagnostic evaluation, you see that it plays more with over reference testing. What test are you comparing this with that? So you take one as a reference test. If I'm going to compare microscopy and RDT, I will take microscopy as the reference test. Now, if I want to use PCR, I'll use PCR.
Yeah.
Now, there are RDTs that can detect close to like 2 or 3 parasites in the blood. These are ultra-sensitive RDTs. When we are doing those trials, we don't use microscopy as a bench standard. We use PCR. Because the manufacturer claims that it can do more. The limit of detection is so low. And we don't use microscopy because microscopy will not give us that lowest thing. We use qPCR. So it's just the reference test. Standard means that you can see an asexual trophozoite. You can see, depending on the microscope you are using, If you use the other microscope, you won't see anything. Even if you put your so subjective. And you use UVC to show you other things. So that now we go to, I think that's the major clarification. So let us promote RBTs and then the benchmarking, the capacity, we must not lose it at all. And then training, microscopy comes with the process. If you don't prepare your film nicely, you will see nothing. You will see nothing, no matter how. And then we want to say the great progress. So where it can be made in the primary healthcare facilities, more testing are done. Only 6% of malaria tests in the database was done by microscopy. So, and the figure we are seeing now, primary healthcare center, health post, everything, the inabilities, we need to get our figures up and we're working with these people. So, we have expanded some discussions here, and I like the fact that we can work with different stakeholders and team. What are the challenges we are likely going to have?
Thank you very much, Prof. I think I see a shift that we need to make, a shift in orientation, which you have highlighted in one of your presentations. In two ways, for our lab scientists to agree and for our care providers to agree that RDT is a point of care test. One of the things we wanted to demonstrate with what myself and Mr. Adenka were trying to do is the issue of client satisfaction in coming to the hospital for malaria treatment. If I go through the process the way it is now, I go see a doctor, he send me for test, I go to laboratory. It's not only malaria tests they are doing in laboratory, there are several other tests. So definitely I'm going to be asked to sit down, wait, come back and whatever. When I come back with that result, I'm going to see doctor again. Maybe the doctor I saw before, I'm talking of secondary healthcare facility. You know, he will then wait, I will queue up again for him to review my result. I find that are not being pleasant to me as a person. That may force me to go to pharmacy outlet and just go and buy mine because your trouble is too much. So I'm looking at a system in which we are patient-centered, looking at it from the angle of the patient who wants to walk in and get treated for his malaria at maybe 1/4 of the time that he currently spend at our facility. In which case, like I've described, if the laboratory will recognize that this RDT can be moved closer to where the client will be seen. If the doctors can accept that this client does not need to come to me, once he's tested positive for malaria, they can bypass me as a doctor and go and get anti-malaria. It would have moved forward better. Thank you, sir.
Thank you very much. What's long waiting time?
Yeah.
And the reality is that in some cases, if entry results are not available immediately, they will move to presumptive diagnosis. That guideline you see here becomes non-operative. Because the doctor will not wait for a patient who should have an attention. I'm not trying to give excuse. That's the reason why the prescription has to be made. But if the same result will be available, and it may not be because of the challenges that we have, it might not be possible. And what is the low cost? Assessing the testing as early as possible. Assessing the testing. They do that triage with their vitals and it goes. If it do not come as a policy imperative and we agree, it becomes a good way to go. Now, we are saying again, in how many places are those things done? In a number of the primary healthcare centers, you have Jews, you have nurses there, I think that should be about close to 60% or so that don't have doctors there, where they do the primary examination and do the outreaches. So we're going to focus on those that they are doing the right thing. In the secondary facilities or comprehensive health centers, where you have the go see initial consultation and come back, then we will take the trial in as a good benefit. And of course, that means it's something. So I can tell you some facilities have started looking at it in Lagos, and they are seeing very good outcome. So they can assess care, and then the weekend. One thing we have seen again is that you have huge bundle of uncollected MP results. Huge bundle of. So the work has been done and ask ourselves, so why are we doing this test if it's not been used? Now the collective of the entire health state will have to sort this out. It's our issue. How do we proceed? How do we go? What do we think are the boundaries? It has to take the National Council of Health to say that RDTs can be done by the medicine retailers. So, and the medicine retailers are empowered now to do RDTs. I'm talking about around 2012, 2013. 2012 or so, yeah, that's when they had to be. But now, let's look at one thing. The countries that have made progress, what are they doing? I'll say now. They are not doing the things we are doing now. Just take notes. They are not, the countries that are making progress. Go to Rwanda. Exactly. They are not doing these things we are doing here. We continue to discuss many things. Senegal rolled out RDTs. And of course, we built capacity microscopy, and they are doing well. Zambia, when they started this policy in 2006, I've sent the publications to you, they saved $1 million from medicines. They saved $1 million that year from medicines. So those countries doing the success and having those, they are doing things differently. If we don't look at democratization, in innovation, throw it open. They monitor. If we told right now our colleagues here, medical laboratory scientists, if they tell you to monitor some things with the kind of workload, you will not be able to monitor. There are things we will not be able to do. But technically, how things work, let us create those opportunities. Get your learning curve, get your reports, get your data, and then follow it. Then the needle can be changing. TP hours cannot continue like this. That is the fact. And our own indicator here is how the state HMIS data is being reduced. Then the stakeholders will have to work with the team handling the DHIS data and what is happening with the data. And we want the lab, particularly, to begin to watch their data in the record section. Watch your data. If you've done the good work and you don't watch your data, it will still come to you as a challenge. The challenge is not be how do we perform the test. Say, this test result is your own. Because there was lack of ownership. So I agree with that, sir. So agreements that the RDTs is a point of care test, that one should not be a problem. In Argentina, I can tell you, in the Philippines, villagers do RDTs. It's the communities that do RDTs. They have a community intervention in Nigeria. The policy is there. They do RDTs. In fact, in Philippines and you have village microscopy health workers, village microscopists. You train them as much as they can. If the work is not distributed in some areas, if it's too heavy, we won't be able to make progress. So I agree with this. We're going to follow you up and we'll be discussing it when next we meet. What likely challenge are we going to have with this work? Please withdraw it for quality testing. So please you let them know in the facilities that we'll be taking one packet.
Do they have enough for you to take one?
No, not just for only the sake of the policy
say one or two things about the patient-centered service. That's concerning the turnaround time. Like in my own facility, that is actually, it actually happened. But when we discussed with our doctor, so there was an agreement that maybe under 5 patients and pregnant women. So when they come for testing, particularly if it's required, if it's contaminated, if it includes MP and full blood count, so we usually use RDT for under 5 years and pregnant women. We use our RDT and do their BCV, so that once those tools are ready, we'll send those patients, those results to doctor, and they should go and see doctor with those 2 tests. So then we then come back for the WBC count and differential, so as to get the access to service. So we do that in our facility. But from this discussion, if it can be applied across every category, so at least the policy makers and decision makers are here, so we can still discuss that one too. And concerning some challenges that we can face, maybe in the field, at times, just at least I can remember that there was a similar program in 2018. At times, we get some ex facility like some of this primary center. So they will tell you that there's a focal person, that's in charge of malaria. And once that person is not around, they will say that you can't get data, that you can't get required information. So I just want to use the opportunity to tell the authorities concerned that once they are informed that we are coming, if I call the focal person will not be around, maybe he or she goes for a particular training. He or she can dedicate someone that if those who come around, this is these are data, please attend to them. At least I can remember that in 2018 we faced a similar challenge like that. So that the focal person is not around. Once it's not around, so you have to come back to that facility again. So, and we also want to seek for their maximum support. So at times when you get some people say, I'm busy, I don't have the time now. So we have to assess patients, persevere, to assure that person that this thing that I've come for is not for me personally. I was sent by the state. You have been properly informed, and they need all this information to assist. Maybe in improving our service to our clients. So some of those ideas we can make them on at times. If the focal person is not around, nobody to give you what you want. So the authority can assist in that regard.
Okay, what we'll do from our side, we're going to share the list of the people on this side, our colleagues that will be visiting, and then by the latest by tomorrow morning, we'll share the health facilities that are likely good to go. By latest by tomorrow morning, we'll share it, and then they can communicate to the health facilities for cooperation. Reason is that, yes, we'll find a way to navigate it, and they have 12 days of work. But I tell you, that 12 days of work, they will not be able to achieve it. They will still have to go, or some they may go separately to those facilities. There are tools which we have designed to get some understanding about how the healthcare providers are doing their work. And then later on, we'll be able to analyze them and see. And then they will do corrective action. So I see them, if they're going to stay in one facility, we'll be there for some hours. Of course, looking at the HMIS reports, monthly reports, and we will not do DQA going to a daily outpatient, but we will not do that. But we'll just see what they've reported. And then the different guidance they can provide for the health facility managers to be able to do their work properly. We will actually go with the full discussion on non-malaria fever illnesses. Just let them know, from what we've figured out, this will be phase 1. Another point, we'll be able to navigate this and put it. I've been thinking of doing one of the first material on that table for so many years. But now we have this opportunity. We're going to take their phone numbers. When they have Android, those with Android, we can communicate with them and resolve their challenges. We want to see positive development, and we're getting back to the stakeholders. So I think it's good. So we'll get the list shared, and then let them wait for us. We'll ask them questions on storage. We'll look at where they are storing them. We'll take the pictures of where they are storing them, because everything must be appropriate, and we'll be able to get this data on. So the cooperation is important. And
my question is about the non-supported global fund facility. And according to what you said, that we need to collect 1 pack, knowing fully that they bought the reagents,
will they be able to give us even half?
Also. Okay, I can even tell you, we have actually done that in this state before. And we got good compliance. We did this here in 2018. But we were not smart enough. That's why you can't remember. Reports don't mean anything. We gave reports to the central people. And we don't know whether reports came to you, but we are decisive that reports, you will get all the feedback. But you're going to get direct feedback as we are having right now in the stakeholder meeting. And so,
I just want to add to this for the EPA officers, as you are going to the facilities, just focus on all staffs in that facility, because majority of the problem we are having, we have some staffs, they are not really health workers, because we are short staffed in some facility and they have to employ some adult staff. And at times, when they are health attendants, they used to do audit. So ask them, everybody that is doing audit in that facility, let them come out and let them know that it's not a fault finding, so that they won't hide anything from you. So majority of our problem in PAC is those people that they are employing when they are not around. So ask them, and if they are not around, they will step down the training to them. Thank you.
Good afternoon, sir. I'm Mrs. Isabella from Mexico. My question is, when you go to the PAC, we have been told that we should be friendly with them, we should tell them it's not fault finding that we have come for. But at times, when we get there, we may be faced with some challenges that, apart from the issue that the person is not on ground, the people might say that they are not able to work doing it. They are not doing RODT. They are not performing it. So in that case, what should we do?
okay. So what I can tell you, we have done this all over, both in the north, south, and they willingly come. They come willingly. Your introduction is very important. Not that we told you it's not fault finding. You are professional, and we told you you are a friendly person. A friend to the facility. And meanwhile, you are one of them. They are your colleagues there, all under this employee of the state council. This is what we want to do. What we see is that they all come. You now want to say we don't even have time to, because we don't assess all of them. But the general message has to be passed to all of them. How it is good, they should do that by the time you leave. And you know, we are going to give them thermometer. Primary health care, Dr. Agushi, we're going to give them one thermometer. Give them a template for temperature monitoring. And after that, they can begin to make photocopies and store the data. They will store it and keep there. It's one of the best storage practices we want to ensure is done for whoever is keeping the RBTs. And the facility has to be clean, the thermometer has to be there. But when we go there next 6 months, we want to see the records that have been kept for us. And that's something we want to see. So I think at the end, you are most likely going to be welcomed. And at the end too, facilities appreciate good things. As you handle them, they will love you. Don't worry. Okay? And you know one of the things we'll bring out is the corrective actions. All the things they didn't do well, you have recorded them and then you correct them. People like being corrected softly. You just tell them it's not your fault. Okay, we see this, we see that, but this is how it will be done. And everybody's happy that, who is this angel that came to visit us today? Okay, pray for me. I mean, they don't say pray for me. When you see a prophet, okay, you want to mention the prophet, pray for me. So you leave your landmark, you have that. you communicate. I did say one thing. There will be a major part of our feedback. There will be a major part of our feedback. We all here will be able to come back in a stakeholder meeting to talk about, in a concise form, what are the SWOTs we are bringing back, the opportunities and the major threats, why things will not succeed in all the things we are doing. It's a major feedback we're going to bring to you in the summarized reports. You're going to 18 facilities now. Facility A, using this parameter, what do you think is the strength in our objectives? Is data keeping or you reconcile? We will not reconcile RLTs yet until next 6 months, but we'll drop the bags and tell them what to be told. What are the challenges? Are there opportunities? So that's the thing we'll give back. But I think if we've said everything, there's no feedback. Any other thing that we should say?
Sir, is it possible for a kind of list of the facilities that will be visited to be
We are going to do that after the stakeholders meeting. You are still here.
not for us, so that when they are coming, they will be assessing us?
They will give a general whatever, but we're going to share it by tomorrow morning.
Yes, aside from thank you, my colleagues here. So I think in addition to what Mr. said, we appreciate too if the LG, the head here can assist us with the contact of the focal persons. Yes, at the LG level. So if we are able to meet that person, the person can assist us with the focal person at the facility level. I've worked at the LG level before, this kind of program, not malaria, but they are very appreciative. When they see you, when they give them proper information about what your mission will have come from, they are always ready to give information. But the fact is that you need to get a contact with the proper person, let them know you are coming. If they will not be available, they will have told you, I'm sorry, I have another program for that particular day, I'm going to schedule it to another day. They give. But when you are there, they are always ready to give information. I've worked with people, I don't have any issue at the edge level. They are even more cooperative than the tertiary or secondary level. So I believe we won't have any problem getting our work done at that level. So,
Ogun State is responsive and is on course. All things will work. Enjoy about 4 list of focal persons in the states.
Can we have the list of
We are going to use just some few. We have some few here familiar with it, and we will learn with it together this afternoon. Okay? And with this one, you can fill and put on your electronic database. So while we are waiting for lunch, to end this session, I know we'll meet with the private healthcare board and the state malaria program manager briefly of this overall intervention. So we have seen the CPRs, we have seen what the healthcare providers can do. So how do you see these interventions going? So we'll hear from you and then we'll take our notes and then lunch will be served. So comments, Private Healthcare Board, we are going to your domain. You are ready? Okay, let us know how you find all of this. We see where it fits already in some of them. And then we are hopeful that with all your support.
yes.
Great. Let's give a resounding applause. coming. You wanted to ask a question that time. Is it okay? It's resolved. Okay. So thank you for coming. We will with the medical laboratory scientists that have been selected. They are ready to go, and then they will be building capacity across board, and then they will do the work. They will do the work.
Much. This meeting with important stakeholders. Okay. My name is Festus Olukayode Shoyinka, the Director of Public Health of the State Ministry of Health. This meeting is particularly gathering important stakeholders, people who have been trained in quality assurance with regards to microscopy in malaria program, and also the key directors in agencies that are relevant to this project. Well, it's about strengthening diagnostic services in malaria program. And I think with what has been discussed here, the state is ready to go along with this because it's going to help the outcome of the malaria program in the state. Thank you.
My name is Mrs. Akitunde Comfort. I'm the President Director of Medical Laboratory Services. I'm here to support this program. We are involved as medical laboratory scientists, and we are supporting the Global Fund program for the eradication of malaria. We appreciate all they have been doing and their support in the state. And we believe that as we cooperate with them and we do our best as medical laboratory professionals and other colleagues, we are going to be successful in the eradication of malaria in the state. Thank you.
Every facility you go to, it means that you cannot take data outside that location. Not take data outside. And your output to us, the call people you met, you spoke with, will be followed. For RDT withdrawal, archival, you're going to ask for the key healthcare provider that does that. Take two names that manage that process in the healthcare facility. Then regularly we'll be collecting them end of the month, are they back? The state is doing already, so we just keep those properly for us for 6 months. When you go back, in the next series, we will not have this meeting. So next series, we only have a stakeholder meeting that will be attended by 4 of us. But we have gotten all your reports. And we have discussed many meetings to show and present results. Your findings are very important analysis of the things you have said. So your record book is very important for you. You'll be recording what you saw, summaries of what you saw in each of the health facility. So, and there are labels for this. Are they giving me labels? Give the labels. Yeah. Give the labels. Then? Okay, I'll send the labels, yeah? Okay, you said you'll do it there.
Yeah, that's what some of them were doing there.
I would rather not say, well, you could have done that before. So you can, this is the teaching. See, note, red indicates not recommended. You will take time to study this yourself. You saw the PowerPoint, other things that can cause fever. It mustn't be malaria, and they don't want to miss that as well. Then how to do the RBTs and the structure there. So you read and believe on those. And I will start to go into their homes. And then we'll do the facility allotments. The sheets we are going to leave for them. We're going to leave these sheets at the head facility. Give that one so they put inside the bag.
Okay, this is like a
Yes. We'll just put inside the bag and we'll keep this. What we'll come to, we'll reconcile this sheet, reconcile the RDTs, and reconcile with the HMIS report. So, and with this one, we can be tracking them. We've actually thought we could get funding, and then, but we're going to do that for microscopy.
Confirm your counting, please. Confirm it. You have access. Yeah, you see now.
She still has more. She still has more.
Level 12. You don't need the that needs brain. And this one that needs concentration. There is no body. So they thought I didn't like them. I'm not content.
You don't pack and get it. No, I don't have it. It's mine. I'm not counting this one. So why did you not pack it?
All right, sir. All right, thank you very much. My name is Wellington Oyibo, a professor and consultant medical pharmacologist. I am the lead of this project, the RDT QAQC project on the job supervision, training, and mentorship of this program. And we're also doing stability monitoring of the rapid diagnostic tests and also still assessing healthcare providers' capacity to perform RDTs and to see overall how the healthcare providers is implementing the malaria diagnosis and treatment guidelines of the country that requires prior mandatory parasitological confirmation of malaria before treatment, and then how the records are properly kept, was testing done properly, documented, and we want to see how this is affecting the overall data in the facility health management information system, the monthly HMIS reporting, and of course how overall it will affect the DHIS reporting in the states. And one of the reasons why we have carved over all of this program and together in this global fund support is to bring value for money by introducing, of course, infusing a holistic intervention, not just building capacity for healthcare providers to perform RDTs, but to bring the stakeholders back who are likely going to take very significant and critical decisions for the states on the positive aspects and how the statewide implementation can be accelerated. So we have in this program, in this current form, one-day orientation, and planning for the medical lab scientists that will be visiting the healthcare facilities. And when they visit, they need to understand the current trends, understand the purpose, understand the tools that will be used in collecting information from the health facilities and how they will interface with the healthcare providers in implementing this intervention. And this is unique because they will bring in their leadership, they will bring their understanding and take it to that level of care at the primary healthcare setting. And when that is done, carefully the healthcare facility raising non-conformities from what they see, then they can institute corrective actions. These actions will have to be documented so that in subsequent visits, they want to see how the non-conformities have been cleared. And in this project, like I said, we'll come back to the stakeholders. We just had finished this meeting with the stakeholders, telling them why we want to do what we're doing. And chief of all, we're even doing what has been initiated here, which is the auditory archival, which will be monitoring and to see how the test tallies with the healthcare facility reports. So, and they're welcoming this. And rather than writing reports which nobody will read, say, no, just bring it here and people fund it. And you can see the argument, the discussions around the stakeholders and how they're going to support this project, how they're going to receive the results. So one important outcome we're looking at is that because we have seen now reported very high test positivity rates, TPRs, from the DHIS data, we will ensure that from our work, we will be having a better, HMIS reporting, and therefore more accurate test positivity rate reporting, and of course seeing how the test is catching up with the use of ACTs, and then that forms the success that we're looking at, and therefore the states can contribute meaningfully in meeting the malaria case management targets objectives, which are very clear, that patients presenting with symptoms of malaria are tested and then they're treated appropriately. And if it's not positive, then they are managed them accordingly. And that becomes a very important target for us. And with that, the healthcare providers are happy, the health facilities are happy, the state government is happy. And then apparently we'll be able to see more refined data. And they can query what is in the national DHIS data if it's not having any correlation. So that's what we're doing. The advantage of all of this is that we work for the common good of the people. We stand with the people, we stand with the government, we stand with the objectives of the Global Fund principles, why they are funded. The funding is to create value and create impact, so we'll be able to have the achievements. And we'll see that the data is changing, and overall we'll see again that the entire contribution from Ogun State is reflecting in their clinical cases that are reported, and therefore on the burden of malaria description in Ogun State. So that is the bottom line, and we are excited about this. We are excited about the opportunity of the Andy Center of Excellence for Malaria Diagnosis at the College of Medicine, being able to provide this leadership in the interventions in the 13 Global Fund states. So we look forward to all the results. We look forward to all the series of interventions we'll be bringing on board every 6 months. Thank you very much. Wellington Oyibo, Professor and Consultant Medical Parasitologist from the Andy Center of Excellence for Malaria Diagnosis that is embedded in the Center for Transdisciplinary Research in Malaria and Innovative Tropical Diseases in the University of Lagos. Thank you.
Thank you. I will be seeing you in 6 months' time.